and the director of the Institute for Global Health and Development at the Aga Khan University. I also chair the Health Sciences and Biology panel at the HEC, and I have been the founding chair of the Research Ethics Committee of the Government of Pakistan for 13 years between 2003 and 2016. So I know a little bit about the subject. So what I'm going to talk about today is largely the issue of ethics and is their considerations for projects within HEC, GCF, and local challenge fund projects, principally those that are related to health considerations. And what I'll try and cover in the next 20-25 minutes is really why is this important for HEC and the universities that are related to this? What are the key issues and what can be done, particularly given the resource context of Pakistan? I'm talking about not just money, but human resources. So the first point to drive home is that human research, subjects research, is now fairly well established. It's not like 30 years ago that people were doing research without ethics approvals. There are several ethics clearance platforms that have been well established at an institutional level, universities, research centers. But more importantly, there is a national structure. So there's a federal National Bioethics Committee for Research, which used to sit within the old Pakistan Medical Research Council, now the Health Research Institute at the NIH. So the principal custodian of national oversight of research bodies is the NIH, largely for projects that involve national scale of projects or multi-provincial projects. In other instances, this is entirely done at a provincial level within the universities and institutions per se, who are all ostensibly expected to have research ethics committees. Now, my concern on this, and the reason why I think this topic was recommended also for the conclusion, is that of the various health sciences related projects that our panel has seen over the last 2 years, presented to the HEC, either in the GCF, LCF, or even National Research Program for universities, the weakest link that we see is on the ethics part. So most proposals don't have a section consistent of ethics review and oversight procedures, or if they do not detail it in any meaningful way. And this includes many of the studies that we see, observational studies, even randomized controlled trials, or studies with a quasi-experimental design. So there's a clear reason for us to be looking at this a bit differently in the context of what we need to do. Now, the role of research in all of this is something that involves a lot of ethical considerations. These projects consist at times of identification of risk factors, but importantly, identification, interventions. What do you need to do to make a difference? And prioritization of those interventions. And these are clearly projects in which, without ethics considerations, you sometimes end up by not considering how you will practically implement. The research ethics guidelines that are generally available globally now are pretty standard, but there are some differences between developed and developing countries that I will get into. And they're all guided by global principles, which every country in the world is signatory to. And it starts off with the codes that were developed after the Second World War because of the consideration of totally unethical experiments conducted by not only the Nazis, but also by the Japanese and other people, principally experimented on prisoners and on other people of the population without any due regard for human safety or human consent. And this led to subsequently the declarations that you see out here, which are many of the oversight governance mechanisms for human subject research. The Helsinki Declaration of the Rights of Human Beings, the CIOMS, which is an international council that looks at medical research and particularly on ethics of practice and research, and several other national bodies which have looked at these over time. They all have certain principles in common. And the few principles that are involved in health research that underpin the ethics of implementing research include, number one, non-malfeasance. Your first responsibility as a researcher is not to harm in any way the participants of the research. The second is, of course, beneficence. People who participate in research are contributing their own self, their own time and effort, risks. And therefore, as much as possible, research has to be beneficent. It must do good to humanity. If not in the short term, in the long term. Research must be fair. The risks and benefits of research must be equally distributed amongst the poor people participating in research. And this is one of the reasons why we have this developing country dialogue around what research needs to be or not. It must be truthful. You do not do research by hiding it under treatment, telling people that they are being treated when they're actually part of an experiment. There are elements of confidentiality. They're very much part of health research. And very importantly, in poor settings, autonomy, where the person who's participating in research has to have the ability to say, no, I don't want to do this, or I'm not comfortable with this. These are the general basic principles that underlay. And they are also areas in which there have been lots of controversies over the last several decades. They include issues like the use of placebos in research. When is it all right to give somebody nothing or a placebo instead of an active ingredient? And this is really important when there is a recognized treatment or a preventive intervention available. Most recently in Pakistan, this controversy has arisen around the use of placebos for COVID vaccination trials. Now that we know that vaccination saves lives and is available, should there be any experiments in which people are exposed to the risk of disease without that knowledge, or be part of a placebo administration without their agreeing to that risk themselves in some way? And this is a global issue, a global challenge. Then assured availability of products of research. There are so many research proposals that come through where people are contributing time and effort in participating in research, but they have absolutely no chance of ever getting those benefits of the research, either in drugs or in products overall, because they cannot afford it. So there has to be a real compact or an agreement with the populations as such on how you would implement this. And then importantly, on the standards and capacity for ethical review of research. I'm going to talk about just two things out of this in the interest of time. One is standards of care. What is the standard of care involved in research that everybody has to be cognizant of? And then what should be done for ethical oversight of research in our universities? And any proposal that's being presented to the Higher Education Commission or any other funding body for research has to take this into account within the proposal itself as to how will you conduct the research ethically. So in informed consent, the basic principle is a fundamental requirement. Anybody participating in research has to give his or her informed and understood consent. Now, it's very important to know the difference between the two. Informed is when you put a sheet of paper in front of somebody and you inform that person, and the person signs because he or she are in distress and they need some care or treatment. But understood is when somebody has really studied and has absorbed what you're trying to do. And many people don't have that as part of their proposal or as part of their research plans. And this needs to be taking into account the diverse population, the illiterate population, people who cannot read will, instead of signing, put their thumb impression, and really culturally different belief systems where many people participate in research because they don't have access to anything else. So it's very important that principle of informed consent is recognized, and most bodies overseeing research will demand that the informed consent be in the local language, that it must be simple, must not be complicated, and the risks and benefits of research are very clearly told to the participants, along with the ability of that person to say no, that you can leave the research at any time if you're not comfortable without any risks to your ability to get care. There are community agreements and benefits that I've just said. When you try and go to a population and do research in that population around a problem area, and you're developing a solution or a potential intervention, then having those benefits available to that population after the research is over, or post-trial benefits, are very important. Even if you're not going to give it to them, but they should have access to it, because otherwise people are participating for nothing other than general good of science. There's nothing wrong with it. Many people do that. but you must make it very clear to people that they are participating in something that they may not have access to. So there is an issue of distributed justice in this. And that's one of the reasons I started off by saying all research must have some benefit that accrues to the population at large. So on standards of care, this has been an area of controversy because of various reasons, like what is the best treatment that you can provide versus what is available. In COVID, a lot of the research that took place in the country at a very early stage of the research was without even any appropriate antibodies, any drugs being available beyond Dexamex. So there was really a question of people participating in research without access to the best possible treatment that could range from ventilatory support to drug therapy, etc. So it's important that we have that in mind. And even if you don't have it, that you discuss with the subjects as to what would be the established treatment versus what is best available locally and in which particular setting. And I happen to think that a pragmatic solution can be. There are some guidelines that are available in global declarations. This is what's in the Helsinki Declaration, first put down in the 60s and then modified about 20 years ago. And it says the benefit, risks, burdens, and effectiveness of any new method must be tested against those of the best current prophylactic, diagnostic, and therapeutic methods. They don't tell you best in what setting, but they give you that general guideline. This has been further modified and explained by many, including Anas. And it says that what your standard of care is, what you're talking about, is what a reasonably prudent physician or a specialist would do in similar circumstances. So it does not mean no treatment, and it does not necessarily mean the best treatment available in the United States. It means pragmatically what is possible in your setting, you ought to make that available to people. And there are lots of definitions that are available in the literature. The point to drive home is that you have to provide something to people who are participating in the research. And in control groups, people are receiving nothing. It cannot be zero care. It has to be the best available national standard or local standard in the public health system that's made available to people. And therefore, the recommendation has been that you should only design clinical trials where the control population will receive established effective treatment that is available in the host country. And I've seen many proposals of interventions around things like non-communicable diseases, infectious diseases that come without any consideration as to what will be offered to people who are not receiving the intervention or in what is happening to the control. So ethics review committees have to oversee that part in terms of protecting the people against the unforeseen and unanticipated effects of research. Now I want to turn quickly to the role of ethics review. And this is extremely important because it's not the function of the Higher Education Commission to be providing that ethics review and oversight. It is the function of the university sponsoring the research, where the research will take place, to have ethics bodies, where this research would be approved, and where prior to submission, some discussion takes place on how you will get the requisite approvals from those organizations. So ethics committees in respective universities, academic centers, or hospitals are responsible for overseeing and acting the full interest of the potential research participants in concerned communities, and they take into account the interests of everybody, researchers, funding body, etc. And it's extremely important that this being done within the consideration of the relevant regulatory bodies and authorities. These are requirements that are now standard WHO requirements also, and they have to follow the regulations that exist. What are different ethics review committees? I mean, they have to have several components they have to be independent. They have to be competent. They have to have members who have good grasp of the science, and they also have good grasp of the ethical aspects of research. And they must do this in a timely manner. So there are some guidelines on how ethics reviews committees should function. They are generally independent of the research team. They are committed by the institution. They are provided support, and their clearance is needed before research starts. Before you recruit your patient, there has to be a discussion in terms of what are your instruments for research, what is your informed consent document, what is your informational document, and what kind of oversight and monitoring will these ethics review committees put in place. And they can be several. aspects to these ethics review committees. I want to turn quickly to who the members of these ethics committees are. And these are generally multidisciplinary. They are not only health researchers. In fact, they should not be only health researchers. They have to have people who have broad experience and expertise in this, but they have to have knowledge of ethics. There has to have at least some knowledge of law, legal aspects of this. So we generally have a lawyer in most ethics committees, and at least one member from the community, people from Awamun Nas, somebody who knows exactly what it's like to participate in research, and it must have a balanced age and gender distribution. So there are some guidelines in terms of who should be the chairpersons, how many members. Generally, you don't have research committees with less than 5 members. There is no maximum, but typically 10, 12 members are there. And you can always co-opt and invite external experts to this. The criteria has to be multidisciplinary, multi-sectoral. They have to have, as I've already said, expertise from a variety of disciplines. They must represent the community, and they must also have ethnic and gender balance. And this is typically how ethics committees are set up. There are many issues in developing countries on any of these, expertise, group dynamics, independence. The one that I want to point out mostly is independence and vested interests. I have seen ethics review committees where they have people from the same department as the investigators themselves, or sometimes even have investigators sitting on the ethics committees. Now, that's completely illegal, and it's not allowed under the broad law of ethics reviews. They have to be people who, even if institutional employees, are independent in terms of their review of this. And they have to have the right balance in terms of how much time they give. And one of the big challenges for our universities is that many of these people are voluntary. They give their time, and they do not have adequate technical support in terms of participation. The community aspect, participation aspect, is one of the most difficult ones. So to summarize, this is one of the big areas of ethics review gaps in Pakistan, but it is much, much better than it was 30 years ago. And over the last few years, every university is expected to have an ethics review oversight body. And it is important that before projects are prepared and submitted to the Higher Education Commission, that there is consideration of what is required for ethics oversight, implementation, monitoring, and annual report. And that these projects, when they are conceived and designed, do not come without a requisite consideration of their ethical design. This is a very important area. I know it cannot be done in seminars only. So this seminar or a short presentation of mine is only an introductory thing, but it requires training of people in ethics review of research. All researchers must be aware of this, and all universities should undertake this. It's become a lot easier in these COVID era by virtual courses. There are many free oversight courses for ethics review committees and researchers available worldwide, many through the NIH and many through the Pakistan Health Research Council also. And they must include experiential learning. So by using case discussion, by using vignettes and self-learning, people can principally go from a very low level of competence to a reasonable level of competence. So I'd like to finish by just making a couple of recommendations. Firstly, this is something that I've already recommended to Higher Education Commission, should be done at the institutional level in terms of institutional oversight, training opportunities which are based on virtual courses, which are based on a range of trainings. Now, we don't have time to make masters of bioethics out for everybody, but there are certain types of research in the country that are being put forward, both to the HEC and other funding bodies. And I think creating a ethical research implementation structure around some of these topics, vaccination research, epidemiological research, infectious disease research, as I've just mentioned, non-communicable diseases, genetic drugs trials, reproductive health, and stem cell and genetic research. Most of the proposals and projects that we have received fall under one or two of these categories. And therefore, it is quite possible within ethics committees to create training modules that would allow this to happen. So thank you very much for your time. I know we are probably out of time. If not, I'll be happy to take questions.
Since Dr. Zulfikar Bhutta has to go at 9, I recommend if there are any questions from Dr. Zulfikar Bhutta on his presentation, you may ask now. Otherwise, you can always email.
There are only 5 or 6 participants, correct?
Yeah.
So I'd be happy to take questions by email also.
Yeah. We'll be circulating your recorded session with all our participants, Dr. Zulfikar, after the session, and I'm pretty sure we'll have some questions that I'll route to you over email, if that's okay. Yeah.
Thank you.
All right. So with that, we'd like to invite our next speaker, Dr. Sarah Rizvi from FC College, who will talk about ethics in her presentation today. Dr. Sarah, please, if you can unmute and start your presentation.
Thank you so much, Umar. Thank you to Umar and Ahad, who isn't here today. I'm wishing him a speedy recovery. Thank you also to Dr. Ruxana for helping to organize this and for including the FCC faculty. So just a couple of disclaimers like last time on the session on the 14th, that I'm going to be talking as much as I can. A little bit, I'll obviously include about clinical interventions. But because my background and the grants that I have received are from the social sciences and public health and that area, I would be talking about examples specifically related to that only. So that's kind of like a disclaimer. And the other important thing to share with you is that I haven't actually won an LCF or a GCF, so I have to share that as well. This year is the first time that me and my team members have applied for an NRPU, but you can see very quickly a summary of the grants that we have won. And I'm going to try my best to share as much as I possibly can. Starting with, before I start the presentation, these are some pre-slides that recently, Sindh Institute of Urology and Transplantation and colleagues from WHO and PMRC, they conducted a research where they summarized the problems about ethics related to research proposal grant writing, which really makes our life easier. It summarizes the challenges, but it also helps us understand where we need to move forward and what we need to highlight for this little training session that we have together right now. So one thing that has been mentioned is that there are a lot of proposals, unfortunately, that are sent in for applications and they haven't received an IRB approval. And if they have received an IRB approval, now this is what the research is saying, is that it's sort of done very quickly. And the reason for that is obviously because of deadlines, timing issues, or because the IRB, didn't have enough resources at the time to do a complete investigation. So here I'll jump to point 4 about the conflict of interest. There may be some of the reasons for these speedy approvals or not gaining approval, but just being granted a number, obviously has issues linked to the quality of your submission, because a lot of ethics will be missing. And this just means that you might not be eligible to apply for international grants, which are very carefully reviewing the ethics element. But some of the reasons, some of the other loopholes over here are that there may be a financial relationship involved with the IRB members being sponsors and being the part of the team as per the grant application. There are also non-financial reasons. For example, maybe the head of the IRB committee at the institution level is obviously they are in favor. We're all a team. We want to win that grant. And so maybe the IRB approval went through very quickly and there wasn't a proper review, or some elements were dismissed or not looked into or not managed as well as they should be at proposal stage. Because remember, this presentation or this training session is really about the proposal writing and not the, what we're setting up to do actually in field. So I'm not going to talk about point 2 because it's really controversial. The other issue is obviously the IRB proceedings not being transparent, minutes not being taken, individual reviewers and their reports not being available for review, the submitting bodies to read and to revise their proposals. So this needs to be a very transparent process as well for Pakistan specifically. Then again, lack of training of the IRB members, maybe not enough staff, maybe not enough representation from different departments. And just to mention over here that we do have a National Bioethics Committee. This became operational in 2004. So this is all very recent actually. But one of the limitations is that it only considers clinical interventions. And so studies that fall under agriculture and economics, and here I want to say that it's really important to have an IRB or an ethics clearance for these areas as well, because there may be issues related. Obviously, you're dealing with human beings, so the ethics element is there. Even if you're having non-invasive procedures, you may have a cognitive-based therapy, which would require ethics approval. But apart from that, if you're dealing with just, resource usage, and then this is an ethical issue in terms of the resources being depleted, and something that, I don't know, use of fossil fuels or use of bones that could be heritage material for the country. So all of this requires, so the point is, whether it's economics, agriculture, any of the social science, it's not just the life sciences anymore that require ethics approval. Now, one of the things that with NBC that was planned was that it would become like an umbrella body that would be supervising and also collating all the information coming from individual IRBs from institutions and research institutions and research universities, but that hasn't materialized yet. Another plan in the making was that the National Bioethics Committee either would be broadened or another committee would supervise all the social sciences research at national level, but that again hasn't come into being yet. So these are things that we have to move towards. Okay, so a little bit about the background of ethics review. Again, this is very recent. I'll skip through this as fast as possible. In 1979, there was the Belmont report, and the 3 principles that were highlighted was respect, beneficence, justice. I think the previous speaker spoke a lot about beneficence. That just means that your research agenda and objectives should be to promote growth, and it shouldn't harm anybody. And then there should be respect for the dignity for all human participants. There should be justice. Here, I'm going to talk a lot about the data collectors and the intervention facilitators. So who you're collecting data, who you're using in your team to conduct that project, there needs to be justice for them along with the participants as well. So in 64, the Declaration of Helsinki, and then in 1982, the Council of International Organizations. This was the international push. And in Pakistan, really post 2004, most research universities and institutes had IRBs. Again, there are issues with quality over here. We've just discussed them previously, but luckily for us, there's a huge growth and there's a realization, there's awareness. Very rarely will you come across a scholar who will say that, no, we haven't gone through our IRB. They might talk about issues related to IRB, but they usually have some form of clearance or a code. Otherwise, a publication is not possible. So again, I'll go very quickly. The intellectual property laws, this was a question on the session on the 10th, that do we actually have any laws? Well, we do. You can see this long list of laws in the black box, and the sections under 478 and 489 of the Pakistan Penal Code also are there to protect intellectual property rights. Usually the ownership policy laws and contracts are made with universities, because we are, individual researchers and principal investigators are usually using the resources and the IT equipment, etc. of the university. But obviously this varies proposal to proposal, and this is something that you would have to be talking about with your team and with your university. But the laws exist, and there may be some need for further implementation and reform, but they are there. So that's good news for us in Pakistan. Okay, now this is where, when we're doing literature review from our research proposal, and I will talk about, I'll link this back to our session on mapping your research proposal, and I talked about negative timelines, the timeline that is before the point of when we start writing our research proposal, so -1, -2, and this is basically that phase. When we're doing our preliminary literature review, and we're studying different interventions, automatically you'll be scrolling to the appendices and you'll see something like this. You will see a protocol paper and you'll see the spirit checklist or different checklists. It depends on the journal, or there are 3-4 different ones, but this is the most popular ones. This is the standard protocol items recommended for intervention trials, and this is used for social sciences and life sciences. I've actually entered data for this because this was my published protocol paper in red. These are the page numbers. So now what I mean by the minus timelines is simply that you need to be thinking about this with your team before you've actually started your research proposal. Because after you've drafted your research proposal, to come back and start entering data for your ethics doesn't really make sense. So here, this is the most important element, I would say, to go sit with your team and take a look at the spirit checklist. Now, another thing in the supplementary reading material that I've sent for the post session, you can email Umar or HEC or myself. You'll notice that there's the spirit checklist templates, but there's also a long detailed description of each of these description items in the checklist. And something that they start off with, interestingly, is saying that every element or every heading under this checklist actually has to do with ethics, which makes sense. I'll give an example before I talk about only the ethics section. The administrative information. Now, this subheading basically has, this 5D component, which is composition of roles and responsibility of the coordinating center. Now, this is going to link to a slide that I'll talk about, establishing and determining contracts with your team players. Now, if there are minimum wages involved or exploitation, you're asking for a small, simple example, you're asking for too many work hours and you're not compensating them enough, then here you have an ethical dilemma. So, and another example, if we move forward under the method section, again, is, let's say, you can pick anything, the eligibility criteria. Let's say you're trying to sample children, and this is usually dissuaded. You really have to convince your IRB for sampling vulnerable populations like rape victims or children or elderly population with mild dementia, because they are not able to give informed consent. So here you would probably either try to target another population, say you're researching special needs children and you want to address and identify the challenges those children face with regards to health. It might be better, obviously, to skip trying to get approval to interview the special needs children as opposed to their guardians. But in the event that you can't, then, and you do need to get interview the children, then you would have to get informed consent from the guardians and or the parents or the teachers and the administration or all of them. So here there are lots of ethical areas. So I would recommend please reading this very carefully. That's why I've attached it as a template for the post-reading session material. Regardless, many of us actually have this, but we don't spend time reading it. And then we land up into problems later. So please do read it. I can't say enough about this. This is the section on page 4 that's most relevant to us, which I'll be talking about in the rest of this presentation. And you'll see from 24 to 31C. Again, I can't read everything, but number one, you need to, 24, you need to get IRB approval. And this has to be a legitimate body, which is going to give you an allocation number, which you can publish. You might want to register with clinical.gov.org or another license, another body that will give you approval, that will take you through a risk review process, that will give you feedback, that would monitor and audit your progress. Okay, number 25, plans for communication and dissemination, who you will be sharing your data with. We'll be talking about this a little bit more, data management. Surrogate authorities, informed consent, I've talked about that. Financial and competing interests of your principal investigators, co-investigators, your sponsors, etc. And any sponsors who will be actually asking for certain material, i.e. who you will be sharing your material with. Will your funding body be involved in your research design and your data collection and the analysis of your findings? Ideally, the answer is supposed to be no. And so I'll skip over here that when this is a published section of my protocol paper, you'll notice over here that I've very carefully written that the funds will be used for blah, blah, etc., etc. But the funding body will not be involved in the study design, data management, or interpretation of data. So you need to declare this in your research proposal, in your protocol paper, and so many other important things. Author eligibility, so I'm going to jump to that as well. Author eligibility is something really important. We talked about this in a previous session, and one of the speakers who talked afterwards said that, you know, we have this issue of being so desperate to get the grant that we do all the work and we assign principal investigator status to a senior consultant or somebody who hasn't really worked on the project. Now that again is against ethics, obviously. We're all desperate for funding, grants and for promotions, but this is something we all have to look into. So eligibility for authorship, I'm not going to read all these points, but these are something that has to be met. And I'll link it back to this, again, publication. You'll see very carefully that the contribution of each author is mentioned over here. And obviously this has to be planned in the from day one, and it has to be included in your research proposal protocol paper as well. So I'll start moving forward. So one of the most important things on that checklist is to ensure objectivity and impartiality. And these are in the gray box are some of the measures for maintaining this. Number one, peer review, consultancy, mentorship, asking your supervisors, your department, your previous supervisors, anybody who would actually be able to give you time and constructive feedback for improvement. And maintaining objectivity is also achieved by having a multidisciplinary team. So, somebody from the public health background, a medical doctor, education, psychology, sociology, social policy, economics, all of the team, IT people coming together at the research proposal drafting stage. What usually happens, the reverse happens, that one investigator from one academic discipline usually writes the proposal and targets that many other people will get involved. But if they're involved at the research proposal stage, you'll probably be able to prevent many challenges or limitations in the future, or blockages, one can say. A separation from the funding body, we've talked about that. International tool validation, it's a good idea to try to start by using an international tool and then modifying it for regional relevancy later, also applying tests for scale reliability. Gaining participant feedback, so usually we think that this should be done after the project is over and you've got the final findings, but in fact you should be doing this at the research proposal stage as well. Plans for fidelity tests, this just means supervising and giving feedback and training your intervention facilitators and data collectors, and attaching your training modules and your supervision checklists for them in your research proposal. It makes a big difference. A blinding of participants, these data collectors and intervention facilitators. Usually we write about how we blind the participants, but not our data collection team. So double blinding really makes a big difference as well for good trials. Preventing contamination, i.e. the control group from crossing over into the experiment group. This is tricky, especially with community and primary healthcare interventions. Usually you're delivering an intervention in a community where the control group can, spend the evening talking to their neighbors, and a lot of information flows back and forwards. So trying to prevent that takes a lot of planning. One example is maybe trying to shift the locations, geographical locations, but then you have to be careful that if you have a different control group location and a different experiment group location, they should be homogeneous in the sense that they should be comparable later on in the future as well. Independent data extraction, this is really important as well. And this just means that once you have the data, you should have clear plans for how different principal investigators will go through the analysis and theme generation process independently, and then they will come back. And sometimes people have a third party who's actually monitoring this. So instead of me analyzing a little bit of the data and calling my principal investigator and saying, this is where I am, where are you? Ensuring that we finish the process before we match notes. And this just means more rich findings coming out later in the future as well. You can also see, conflict of interest and competing interests. These have to be declared if there are any. Consent for publication from all authors or participants. Again, if this is relevant, you might need to go back to your participants and ask them for permission for this, unless you've already done it in the initial informed consent letter, etc. Safety for all participants, can't stress this enough, but I'm going to give you examples, especially with social science research. When you go in, try to collect data about domestic violence, intimate partner violence, you have to be careful where that data collection is taking place. If it's being done, let's say at a basic healthcare unit, was a relative accompanying the woman? Is it a closed space where you can't be overheard? Even if you're not overheard, do you think there would be a backlash by the male relative who's accompanying the lady because you've actually requested for a confidential area? These are all limitations to actually freely collecting data in the community and actually sitting down and thinking as to where you can collect the data without it becoming a problem later on for the participant. Similarly, collecting data from elderly in old age homes, usually their guardians and their caretakers or the administration of the resident areas are there, they're present. So if you ask the elderly about their environment or the cleanliness or whether the bathroom is functioning, where you may exit, but you may leave them in a hostile environment where they would face backlash from their caretakers. Here, just to talk about solutions, one solution that I've used is that I've offered free psychological services in the informed cover letter, so that people know that immediately, even though they're recounting maybe challenges and difficult life experiences, they have somebody to call for counseling, for just somebody who would hear them out. Also providing them access to homes and shelters and proper addresses where they could seek a refuge. That also helps. A third area is actually just taking them out in the open instead of discussing things in private with them in their home or in a microfinance institute or at a basic health unit, asking for a group area where there's a common compound and people are sitting on the charpai or they're sitting in the garden and they're talking to each other. So you can do it one by face to face and ask the other group members to be at a distance where you can't be overheard, but still relatives would not know that, would understand that nothing confidential as such is going on and there are no closed doors. Things like this. Again, this is team effort, actually sitting at the pre-proposal draft stage and thinking how to create safety and anonymity and confidentiality. One other thing that I'll mention over here, an example, is that sometimes with is anonymity over here, I think I'll jump over here, confidentiality and anonymity. There have been cases where people have complained, not because you've shared their name, but because you shared so much of information pertaining to them that they can be traced back. Now, one example of this is, for example, there's a public sector hospital in a city and there's only one, there's only one hospital and there's only one nursing supervisor. And in your research, if you start talking about that nurse supervisor who is also, and you share their designation, then automatically the whole city or a lot of people will be able to trace that person back. In which case you have to be very careful to announce in your research protocol that I'm going to be not only hiding names, which is obvious and apparent, but I'm also going to be changing around designations and changing around city names to provide even more anonymity. Similarly, when we're preparing files for audit or to disseminate. So for example, whenever I have data sets, I start uploading them on Mendeley. I give them to my editors to upload with the published material, or I can upload them on ResearchGate. And this allows other researchers to use your work and use your data sets. But before that, you have to be very careful, obviously, to code this data. So you'll notice over here, Madam Fatija Burhan and I, what we've done is that she as principal investigator had the names of the participants, but when she started transcribing the data, she immediately started coding them. And that code matching is there on paper and with her, held exclusively with her, but nobody really knows who this participant is. So all of this is very important. That should have been together, safety and confidentiality and anonymity. Again, honesty and fairness of the principal investigator or the team. I'm not going to talk much about this. We've talked about vulnerable populations. We've talked about exploitation of informal workers. But what's the solution to that? The concorded contract for research staff. This is amazing. I've attached it to the supplementary material. This is something that I use as well. Sometimes we can't follow it to the letter. I myself have a confession that I've paid peer community health workers 1,500 rupees a week for a 3-month project, and they were underpaid simply because I didn't have enough grants. And so, I had wonderful co-investigators where we were pitching in and transferring them money on Easy Pesa, but still that's not enough. And some of you'll need to read this in detail yourself, but some of the basic principles of this concordant research contract is the recruitment process, assuring that your data collectors, your intervention facilitators, your research assistants receive training and continuing development, because sometimes that certificate is more important for them for jobs in the future. Ensuring ensuring that they have minimum pay, maybe they need transport costs, maybe they need food stipends. And then obviously we're going far ahead over here. Some people are lucky enough to hire research assistants on long-term basis and even provide them sick leaves, pension, medical allowances, etc. But clear roles and responsibilities is really important over here as well. Academic integrity and justice, we've talked about eligibility for authorship, but what's also, and these are the basic ones. So I'm sorry, I'm not talking about anything on the, on this, what is this, on the left side, but rather the right boxes, because those are examples which will add a little bit more value to the presentation. But I'm going to mention a plagiarism over here. A lot of the times our proposals, in most in all cases, our proposals are actually plugged into a similarity index. And over here, a lot of rejections take place because of unintended plagiarism. So I'm going to talk more about that. That's one of the aspects of that is self-plagiarism. You've done a lot of research, which is why you're actually applying for a grant. And as a principal investigator, we tend to copy paste our own work. And then we get caught in plagiarism. Mosaic plagiarism is when we're using a lot of other material and we're just paraphrasing, we're just changing the sentences and the words. And sometimes people are not doing this intentionally, but they're just doing it because they're really passionate about this gap and they want to do the intervention, etc. But I think avoiding this plagiarism also helps us on many levels, but the most important level that it helps us with is identifying a true research gap and a true and an relevant research project to deliver in the market or in the community. Direct plagiarism, I hope none of us are guilty of this. So we've talked about confidentiality, consent from different parties. What's unique over here, I'll just talk about some of the different things. It's not just consent from your participants over here, but sometimes in most cases, especially with social research, you need consent from family members as well, husbands, in-laws, community members before you access the community. So gatekeepers, you'll notice, people in powerful, sometimes religious leaders, before you enter into their area and start researching their community, sometimes you would take consent from them. This little box by Yip on the right has all the essential components of that informed consent letter. Yes, you can take a thumb impression, or you can take a signature, etc. You can even take a verbal consent and you can record it for people who are not comfortable with the thumb impression and the social distancing these days in Corona. But these are the several elements that have to be part of it. Again, we won't read it out, but just to talk about a couple of them: the rights of the participants for withdrawal, the rights to volunteer willingly to be part of the research project regardless of stipend. And here I'm going to talk about in some cases, a stipend is very important, and it's important to include it in the informed consent letter. One of the examples, again, is that when you're doing long-term interventions with women of reproductive years who have a lot of children and they may be pregnant as well, currently during the 6 to 9 month intervention, then they need a lot of monetary help in terms, and also non-monetary help. I'll give you two examples. Number one, they need help to sort of give money to their relatives in the home to substitute for them for domestic work. Another thing that they need help for is child support, child daycare centers. Otherwise, they can't be part of a proper training session or an awareness session or an intervention to for whatever intervention you're delivering for. So all of this needs to be very clear, because this will actually also improve your enrollment, retention, attendance, and retention. So a lot of things are linked. It's not just just about the ethics, or that informed consent letter has to be there and it should have all these features, but this has a linkage with broader ethics. The woman, do you actually want to enroll a woman and convince her to be part of a study, though she's giving you willing consent, considering that she will be part of a 9-month intervention and will be giving you 3 hours of her time per week, and her children will suffer the consequences before it, or she will suffer some consequences from her in-laws because she's not there to deliver the services that she usually does for home care. All of these things are the responsibility of a principal investigator to think about. How much time do I have? Audit and dissemination, my last slide. This is really important, and people wonder, why does this come under ethics? well, if you're doing your research and it's not replicable and it's not shared and you can't share it with others, and it's of no value to people, your data sets, your publication reports, the narration of what actually happened during your focus group discussions and your qualitative interviews, then it's unethical. Basically, you've wasted resources, time, energy, the grant allocation. So in your research proposal, not only should you have a clear outline of how you will audit a report, you can share whether you will be sharing it quarterly, at a half stage of your intervention, at the end of your intervention, who you will be sharing that audit material with. Again, you have to be careful to code your data before sharing so that anonymity is maintained. But you also have to have clear outlines for dissemination so that that research, even 20, 100 years from now, is of benefit to your community, to researchers, students, etc. And that's a wrap. Thank you, everyone. Thank you, Umar.
Thank you, Dr. Sarah, for a fantastic presentation. Unfortunately, we had this issue with Zoom and lots of our participants couldn't join because of passport, but we'd be sharing the link with everyone after this session. Since we have limited time and both of you, Dr. Zulfikar and Dr. Sarah, are going to leave very soon, perhaps we'll take a pause and see if there's any Q&A session we can have in this short period. Anyone, if you have any queries on the two presentations we've had so far, please raise your question and we'd be very happy to respond to that to our panelists. So I don't see any questions in the chat and I don't see any hands. Dr. Sarah, I think we're good from here. I know you have a cutoff at 6 and Dr. Zulfikar has a cutoff at 9. So we'd perhaps close this session early today. And there may be some questions and queries over the email that I'll be sending to you and Dr. Zulfikar, and would appreciate if you could perhaps respond over the email any unanswered questions and queries for this session.
Thank you.
Dear Dr. Zulfikar, you have something to, if there are any closing remarks you would like to give?
No, just thank you. Thank you. This is something that HEC needs to do a lot more systematically. So I hope that some of the recommendations from this particular set of training sessions will go back to the research directorate, and we may have a chance to look at this in terms of how this can be done a little bit more. Thank you.
Yes, we can also, some of your recommendations I've noted down, Dr. Zulfikar, and I think it's very important that we have a separate session, perhaps with the new DG R&D and with yourself on some of your recommendations for HEC.
Has a new DG been appointed?
Yes, a couple of weeks back he's been appointed. So perhaps we can have that session at your convenience. Okay. I'll write to you over email and we can schedule that at your convenience. Yeah.
Okay, thank you.
Thank you, Dr. Zulfikar, for taking time out today, and Dr. Sarah for your time also. Thank you everyone for joining today.